All right. Hi, everyone. My name is Alex Reynolds. I am the host of the Hot Topics Neurocritical Care Society podcast. I am a neurointensivist at Mount Sinai Hospital. And I just want to remind you all before we start that you can access the Neurocritical Care Society podcast anywhere you get your pods. Add us to your favorites and be sure to never miss an episode. And also that NCS offers free continuing education credits for listening to select episodes. So if you listen via the NCS Learning Center and complete a short survey, you can receive your free credits. So I'm really excited to introduce two pharmacists today who are going to be participating in a pro-con debate about two of the controversial medications in the neurocritical care community. So with us today, we have Colleen Bond. She is a PharmD who works at Westchester Medical Center, and she rotates both in the emergency department and in the neurocritical care unit. And then we also have Andy Webb, also a PharmD from the Massachusetts General Hospital. And our hot topic today is going to be the use of Nicardipine versus Clevidipine in patients who have neurocritical care disease processes. So first of all, I just want to introduce both of you and say hello, and thank you so much for joining us.
Yeah, thank you so much for having us.
Excited to be here.
So I think, one of the controversies that we have seen in neurocritical care is the efficacy of Nicardipine versus Clevidipine. And I know that this can be one of those topics that really divides people strongly into either one camp or the other. And I'm wondering, maybe, Andy, if you could sort of give us an overview from a pharmacy standpoint of why this has become a question at all and why people have such dramatic responses to this question.
Yeah, definitely. So I think we can all agree that in a lot of our patients, really blood pressure plays a role in some capacity for a number of our kind of key diagnoses. So be that ischemic stroke or intracerebral hemorrhage or subarachnoid hemorrhage or even traumatic brain injury, oftentimes we'll set some systolic blood pressure goal, which what goal you set would be the topic for a whole separate podcast. But for the most part, we're going to be oftentimes bringing blood pressures down with some drug. And most of the time when patients who are admitted to the neuro ICU, usually the easiest or the most kind of straightforward way to achieve that goal is doing some continuous infusion. And, sometimes it's maybe because patients already failed an intermittent IV push of labetalol or hydralazine, or for whatever reason, they're so refractory to other agents that we go right to a continuous infusion. And for the most part in the neuro ICU, our two options are mostly going to be Nicardipine or Clevidipine. You can make the argument for labetalol or some of the other beta blocker infusions, but really those two agents are going to be the things that are the two agents available. And a lot of the controversy comes from basically debate over whether or not there are differences in how well they work, how fast they work, whether or not there's differences in the ability to achieve your goals. And the big thing that's oftentimes relevant is cost. And so the two of them are quite disparate in the cost, and it also varies on how institutions compound each of them, if they compound it at all. And so there's a lot of variability in basically access to any of the medications, how fast you can get it to the bedside, how fast you can titrate it, and kind of how people are comfortable using one over the other. I think to a large degree, that's really how we've gotten into this controversy, so to speak, as to whether or not one is better than the other.
Awesome. So maybe Colleen, can you comment a little bit about cost issues between Nicardipine and Clevidipine?
Yeah, absolutely. So I think just for everyone to know, Clevidipine comes in a premixed vial that's ready to use, and Nicardipine does come in premixed preparations, but also you can prepare these in your pharmacy as well. So I think depending on what institution you work at, you may have different things available to you. But because Clevidipine is one of the newer agents and kind of a third generation agent, it does carry with it a cost. And it is, can be, when we looked at it here, we use a compounded product. It was twice as much to use clevidipine, but could be even more substantial depending on what sort of contracts you're available to get through your pharmacy. So each institution, that cost difference is going to be different depending on what products you have and what contracts you have, but the cost will always be more for clevidipine versus nicardipine.
All right. And so, Colleen, I think you're going to maybe, I gave you that question so that you could sort of be team nicardipine for today. And Andy's going to be team clevidipine, although just for everyone to know that Colleen and Andy are both taking sides for the sake of academic argument. And we'll ask them at the end what their real true feelings are before we let them go. But so I wonder then, Colleen, like, do you think cost is the major reason to avoid using clevidipine, or do you think there are other reasons to prefer nicardipine?
Yeah, I think that's a great question. I think the cost is definitely a factor. I think when you look at the pharmacokinetics of the two agents, it seems like clevidipine would be a real slam dunk and would really be the agent that would get you where you need to be. As Andy alluded to, we're trying to bring people's blood pressures down, and those goals obviously are going to be different for each patient. But when they have kind of studied this in the neurologic patients, whether it be hemorrhagic or ischemic strokes, trying to hash out, who can get me to my goal systolic blood pressure, they haven't really been able to show that. And so I think that you have cost, but you also have clinical efficacy to think about as well.
All right. And I think, yeah, that is a big question usually, is how fast can we start getting the blood pressure down? Andy, I wonder if you can comment or maybe even educate us more about this purported shorter half-life of elimination, because I think that's what a lot of people cite for the reason to use clevidipine.
Yeah, definitely. And that's really the main driver of its development, right? And so clevidipine was intentionally designed to be this rapid acting, easily titratable, high response rate calcium channel blocker. And so nicardipine, I think some people oftentimes forget just how long some of its onset and duration actually is. And so we think of nicardipine as this nice titratable continuous infusion, but sometimes we conflate that with, say, our pressors, which are almost like instant on and off. But nicardipine's onset of action is anywhere up to 30 minutes, and its duration of activity at whatever rate that you set can be up to 4 hours and even longer in hepatic insufficiency, where the patients are having challenge actually metabolizing the medication. And so nicardipine can take up to 15 to 30 minutes to actually start working. And then when you shut it off, say you've reached your goal or you've overshot your goal, it may stick around for quite a bit longer than that. It also has kind of bimodal elimination. So there's a somewhat faster half-life initially, and then a slower tail that kind of lingers for a long time. And that is highly variable dependent on patient's hepatic status. Where clevidipine was specifically designed to be basically metabolized by plasma esterases. So it's independent of hepatic function. It essentially is there to almost instantly be metabolized within the serum itself. And because of that, its onset of action is much faster. So it is an onset of action of about 2 to 4 minutes and a duration of action of anywhere from 5 to 15 minutes. And so the main advantage is that when you start clevidipine, you should be able to rapidly up titrate it. So traditional titration instructions for nicardipine are you can go up by 2.5 to 5 milligrams every 5 to 15 minutes, where clevidipine is designed in such a way where you're supposed to be able to double the dose every 60 to 90 seconds. And so if clevidipine is kind of used in such a way to harness the capabilities of its pharmacokinetics, you should be able to really crank the dose up to achieve your goal in a very rapid fashion. And that's really the pharmacokinetic advantage that clevidipine has over nicardipine.
So that sounds like what a pharma rep might tell me as a reason to use clevidipine. And I guess, Colleen, as a team nicardipine, what would you comment on? Like, do you think that sort of pharmacokinetics and pharmacodynamics are clinically relevant in our patient populations?
So I think that the pharmacokinetics are definitely different, right? And I think the data is there to show that. And I think the rapidity of which you can titrate up your clevidipine to feel like you're doing something, right? But oftentimes when you go into actual clinical practice, are you really taking a vital sign every 90 seconds to titrate up? Are you going to have, an A line in the emergency department to be titrating every 90 seconds? Or really in clinical practice, do you have Q15 vital signs and it's not really being titrated? So I think it does have those pharmacokinetic profiles, but are we really set up to capitalize on them in clinical practice? I think is something to consider.
I guess another natural question then might be whether there is a disease-specific reason to prefer one over the other, whether it be intracranial hemorrhage or the postoperative patient who might be at risk for intracranial hemorrhage, or hypertensive emergency and press. Do you guys have any thoughts, or do you know of any literature that's kind of focuses on a specific disease process?
Yeah, so I can start here. So I think it's a great point that one of the main limitations of clevidipine is to take advantage of its kinetic differences is you have to use it in such a way that you're taking advantage of the kinetic differences. So I think that there is some data that suggests that if you do have the capacity to do that, you really can see some of the benefits. So the Accelerate trial was one of the first prospective trials, at least specifically in the neurocritical care population, to kind of look at this. And so Accelerate was a relatively small single-arm prospective study that enrolled patients with symptomatic spontaneous intracranial hemorrhage who presented within the first 6 to 12 hours of onset and had an elevated baseline systolic blood pressure above 160. And essentially the way that the study was designed was, and this kind of gets to some of the feasibility of doing this in clinical practice, is basically the investigator hung around and made sure that the clevidipine was used in such a way to optimize its ability to control blood pressure. And so it was a tiny study, so they only enrolled 35 patients and ended up excluding 2 because they were found to be ineligible afterwards. But in the 33 patients that they were able to analyze, when clevidipine was started, in patients who had a baseline blood pressure like 180 to 190, they reached their defined systolic blood pressure goal of less than 160 in about 5 minutes. And so if you do have the capacity to control the dosing in such a way to optimize its kinetics, at least with some of the prospective data that we have, you really can achieve those goals in a extremely rapid fashion when you are kind of titrating the drug in such a way to kind of optimize that.
I'm sure that small study probably was not powered to see any difference in outcomes, but I'm wondering, do you think that either of you think that there's enough evidence to suggest that rapidity of blood pressure control, I think, which I guess is, we're talking about minutes to maybe an hour. Do you think that has functional sort of effects on outcome?
Yeah, I guess it kind of depends. And to a certain extent, I think that as you interpret some of the Interact 2 and now Interact 3 data, we at least show that achieving your goal, the faster you achieve your systolic blood pressure goal, the higher the likelihood that you will have a functional outcome. I think that the granularity of that speed has not quite been defined in the same way that, say, we have for TPA or tenecteplase, where each minute will prevent disability to a certain degree. But you definitely could make the argument that that some of the data with nicardipine, where especially if you need to have nicardipine compounded in central pharmacy, like there was one study that was published out of a center that compounded their nicardipine centrally but had clevidipine available in the Omnicells or their dispensing cabinets in the emergency department, where the time to blood pressure control was almost an hour faster in the clevidipine arm, mostly because it took so long to actually get the drug to the bedside. And so I think when you have some of those differences where the difference between getting the drug in the patient can be quite prolonged, you might actually start to see differences in outcomes. But at least I don't know of any data that's quite powered enough, because we've barely achieved that with our large prospective randomized control trials, that's successfully actually been able to see a difference between the two agents from a functional outcome perspective.
Colleen, can you tell us more about compounding nicardipine versus, I know that they do have premixed bags, and what's the advantage over compounding?
Yeah, that's a great question. And I think each institution probably handles it a little bit different. So as I mentioned before, there are premixed bags available that come 20 milligrams or 40 milligrams in a bag. And knowing the dosing that's available, often patients can require up to 15 milligrams per hour. So while it's ready to use, nurses would have to be going back to rehang new bags for these patients quite often. And also this comes with a great deal of volume that these patients would receive. The American Society of Health System Pharmacists actually publishes a paper looking at standardized concentrations of medications for safety reasons. So in this document, they list nicardipine. You can make it in a 0.1 milligram per ml or a 0.5 milligram per ml concentration. This more concentrated form of nicardipine is the same concentration that the premixed clevidipine is available in. Now, while you'd have to then have this product made within your pharmacy, so you have to have the staff to be able to batch this and kind of know how much do you need to have on hand, where are you going to store it? Do you have refrigerators in different areas that are able to keep this on hand? So there's great difference in the availability based on your institution and what they've decided. Not every institution follows the American Society of Health System Pharmacists standard concentration recommendations. They're just that, a recommendation. So if you're a smaller institution and you're not having a high volume of patients requiring nicardipine, you may just be wasting resources pre-making these bags, expecting these patients to come in. Whereas if you're a higher volume center, may make more sense for your pharmacy department to compound these products, knowing that your usage will be there.
That's really interesting. And going back to the fact that you work both in the emergency department and in the neuro ICU at Westchester, I wonder, do you think that there are reasons to compound in one place versus the other? Or, I mean, you're a pretty high volume center altogether, but I wonder if there are sort of reasons why you might decide to compound in one place rather than the other.
Sure, I think that's a great question. And we've actually looked at this because this was a hot topic, evaluating whether or not to have clevidipine available for patients at our institution. So this was one of the things we did look at. The volume of usage of our bags was pretty consistent between the emergency department and the neuroscience ICU. Most of those patients were initiated in the emergency department and then continued on these agents in the neuroscience ICU. So it's one pharmacy that services both of these areas. So if you're compounding it for one area, you'd be sending it to both. But one of the things to evaluate would be your PAR levels, or how many should you have available in each of these areas at a certain time. Because if you are telling providers you're going to have something available to them for each ischemic stroke, each hemorrhagic stroke that comes in, you want to make sure that it's actually in the refrigerator and it's not a stock out and you're causing a delay in that patient. So you want to be able to have consistency in care. So your nursing staff and your providers have some consistency in what's available to them to practice.
Got it. Andy, I want to maybe switch gears a little bit and talk a little bit about how the two drips come. So clevidipine is a lipid emulsion, and I know a lot of our patients are also going to be on propofol potentially. Do you think there's any sort of downside to having clevidipine as a lipid emulsion?
Yeah, so I think to a certain extent, it's largely the same downside that we think about with propofol. Something that's a little bit different about clevidipine is twice as much lipid per volume as propofol provides. So that is one thing to recognize, is that when you're actually looking at clevidipine's package insert dosing, the reason that the package insert caps at 21 milligrams an hour is actually because that's the maximum recommended amount of lipid you should give a patient in a day. And so that is kind of one consideration, is that hypertriglyceridemia and potentially pancreatitis associated with that. Not something we typically think about with blood pressure meds, But when you do have a patient who is, say, on concomitant clevidipine and propofol, serial monitoring of triglycerides is really important in this patient population. I think the good news is that even in some of the studies that have gone up to 32 milligrams an hour, which is like on the higher end, if not the highest dosing that's kind of reported in the literature, rates of significant hypertriglyceridemia are actually like quite low, and even lower than you might expect with propofol, where a lot of the relatively small retrospective studies and the very small prospective studies, many of them don't have any cases of hypertriglyceridemia at all. And so at least in my own clinical practice, I have really yet to see some of those extreme hypertriglyceridemia cases that you sometimes see with propofol, which might get to differences in hepatic function of the processing of the different lipid products. But regardless, that is definitely something to keep in mind, that when you do have somebody running on clevidipine, not only do you need to monitor triglycerides, it's also providing calories. So you want to make sure that your dietitian is keeping track of the volumes of clevidipine patients are taking to account for their tube feed requirements if they're on tube feeds. And it's just like a slightly different way of monitoring than we typically think about with nicardipine. But other than that, kind of the advantage of having it in a lipid emulsion allows clevidipine to be more lipophilic and faster acting at the vascular level. So that is kind of the trade-off of we get these great kinetics, but we have to just deal with the fact that it's mixed in a lipid. But we're all very comfortable with monitoring propofol and some of the consequences that come with the lipid emulsion there. So it shouldn't really be too much different than that.
Right. Interesting. And nicardipine is in normal saline. Is there any data on rates of hyperchloremic acidosis in patients, or are the volumes really not that high?
I'll say that I'm not familiar with that particular endpoint, but what I will say is there is good data that Nicard gives you a lot more volume. And so I think you could probably extrapolate that, with the amounts of volume, it may contribute to hyperchloremia, but pretty consistently in almost every study you look at, over the course of therapy, or even in just the first 24 hours, patients get significantly more volume when they're on nicardipine versus clevidipine, which isn't necessarily the end of the world in a lot of our patients, but can be, especially if you have patients with cardiac pathology, that you do want to be very intentional about how much volume you're giving them.
I would like to comment too, it would depend on which prepared product that you were using. With the more concentrated preparation, if someone was on clevidipine 5 milligrams an hour, it would be about 10 ml per hour. Comparable doses of nicardipine of 10 milligrams per hour in that concentrated form would only be 20 mLs per hour. So I think a lot of the trials that they did look at were using the ready prepared nicardipine, which is probably what most institutions will have available to them.
I wonder about whether you think that there is a location in the hospital that lends itself more, whether it be the PACU or the emergency room, or even, on stroke ambulances, for example, where we may know even before the patient's in the hospital that the patient has an ICH and needs blood pressure lowering. Do you have any thoughts about safety of using this in kind of non-traditional areas? Or do providers who are using these medications in the PACU or in an ambulance, do they need to know anything in particular? I kind of just came up with that question, by the way. We'll cut that part out, but and you can say it's a terrible question and we'll just cut the whole thing out. That's fine too.
I think it's a unique question. I think because cost is a factor, and I think that there is probably a place for clevidipine. I think people are trying to find that place while still keeping control of it, so it's not initiated and continued for days and days and weeks. I think it really comes down to it's got a great pharmacokinetic profile, but I think it's really the putting it into practice and being able to titrate it that quickly. And a lot of times in these patients, when they come into the emergency department, there's a lot going on. They're getting their scans right away. You're maybe consulting neurosurgery. You're getting the neurology team on board. You're trying to get lines in these patients. You might only have one line. What other medications do they need? Clevidipine has concerns with its ability to be run with other medications. So how many lines do you have at the moment? Do you need to stop it to give something else? I think looking at the pharmacokinetics, the ED would make the most sense. Get that blood pressure down quickly. Maybe this patient's a fast bleeder, right? They've been talking about that. Who's like a fast bleeder. But there's a lot going on. So my concern would be how do you do that in practice? How do you take the most advantage of this pharmacokinetic profile for the best benefit for the patient?
Yeah, I would agree with that. Where the operational aspect, it can be challenging. I think one obviously the advantage that might be particularly present, especially if you have like a mobile stroke unit, is the premix nature. If depending on the kind of stock of your hospital, clevidipine is usually going to be a little bit more readily available. Additionally, while this isn't the biggest concern most of the time, nicardipine can be a peripheral IV irritant, and so if you do have kind of like a ratty peripheral IV, if nicardipine actually might not actually be the best agent if in case it kind of increases the risk of blowing that IV, where clevidipine tends to be a little bit better tolerated at the peripheral sites. Usually not too big of a concern. It's not the kind of thing where nicardipine has to be given centrally, but it is one consideration, particularly if you're going to be giving this in the pre-hospital setting.
I do want to ask about something that is somewhat anecdotal, I would say, but I have heard it from other colleagues as well, that there seem to be patients that just don't seem to respond as well to nicardipine. And then you're maxed on nicardipine and they're really not doing much. And then you switch them to clevidipine and all of a sudden their blood pressure is responding. And I don't know if that's because of the pharmacokinetics of it, or if there are other reasons that some patients might not be nicardipine responders.
Yeah, so I personally have also had this experience where you have somebody who's on 15 of Nicard and their blood pressure is still hanging in the 170s. And I've also had success getting their blood pressure under control with clevidipine. I think it's kind of tough to pinpoint why that might be the case. Like one thing that really is lacking across the board in all the literature is exactly what's a comparable dose between the two of them. There's no good conversion from nicardipine to clevidipine. So it very well might be that we just are comfortable going higher on clevidipine than the relative nicardipine dose would be, right? So like the literature supports going up to 32 milligrams an hour of clevidipine, and who knows, maybe that's twice as much nicardipine. There's just not like studies looking at differences in vascular reactivity from a dose-based perspective. There is a little bit of evidence on this though. So there is one single center retrospective study out of Ohio State that specifically looked at post-operative neurosurgical hypertension in patients who had actually failed nicardipine. So they were not achieving their goal despite maxing out on nicardipine. And in their whopping sample size of 12 patients, about a little over 90% of those patients did achieve their goal on clevidipine. And so it's, while, maybe 12 patients you could also call anecdotal, there's at least some support in the literature that if you are failing nicardipine, before you start like cranking hydralazine or some suboptimal IV or oral agent, there might be some credence to clevidipine having a little bit of an edge in those calcium channel blocker resistant patients.
Is there any sort of, I know that I don't know the literature as well as you guys do, but what kind of data do you think we still need in order to settle these sorts of questions? Like, if you guys could just create a couple of, randomized trials and I gave you all the money, like what would be your dream questions to answer about this debate?
I think everyone's tried to find out, which one's going to get you to your goal faster. But in a lot of these patients, as Andy alluded to in the beginning, we don't really know what is the ideal systolic blood pressure for these patients. So I think that's what kind of complicates answering this question, because, the numbers are so different in each patient. I think, clinical outcomes are probably the most meaningful, but there's so much that these patients, that changes. So how are you at what point do you look at those clinical outcomes? Hematoma expansion maybe is this like a good marker. There's good markers, but I don't know. Andy, what do you think?
Yeah, so I think there's a couple of things that are just like perennially missing in every single center retrospective study that's looked at this. And I think, even if it wasn't asking for the $1 million grant for that dream RCT that's never going to happen, I think one thing that would be nice in the next single center retrospective study that's inevitably going to come out is how our centers actually using the drugs, right? And so there's at least 6 or 7 studies that have looked at time to goal between nicardipine and clevidipine. And all of the studies describe how their center recommends the doses are titrated, and they're all within package insert recommendations. Several of them suggest that, they're actually doubling the dose every time it's eligible, the clevidipine dose every time it's eligible for titration, which is fantastic. But none of the studies report whether or not that actually happens. And so it's really challenging to assess the differences in these time to therapy or time to systolic blood pressure goal, because there's no way of knowing how the drugs were actually used. Few of the studies actually report doses. A lot of times it's really just like a straight cost analysis or a volume analysis. And so I think, honestly, the simplest study to do that would really help address this question is, we all talk about the theoretical pharmacokinetic benefits, but does that actually translate to clinical practice if you're using it in the way it could be used? Or is it just being used in the way that Nicard is being used? And so I think a great way to look at this is basically like how many dose titrations were required to hit your goal, independent of time, and how quickly in between each dose titration were nursing or staff able to kind of make those changes. So I think that would be a huge thing to just help put to bed, like, can we even use clevidipine in the way that it is intended to be used? Because I think if it turns out that, in a huge population of neurocritically ill patients, everybody's clevidipine is titrated every 30 minutes, then it's like, what's the point? And then there's really no there's no advantage to using the drug if we can't use it in that way. And then obviously, I think the bigger things would be, is more rapid control associated with reductions in hematoma expansion. Is the time to blood pressure goal lowering associated with better functional outcomes? Like, I think some of the Interact 3 data will be really interesting, because if you dig into the supplement of Interact 3, like how they used meds is like a little interesting, at least my biased, Northeast United States academic practice, right? Recognizing the different settings that the study was done in. But what I hope we'll be able to see with Interact 3, if they end up doing some post hoc analyses, is whether or not there are actually differences in the agents that were used, which hopefully we'll be able to additionally address some of these questions. I think that we have a decent amount of data, and overall, retrospectively, it doesn't seem there's huge differences between the two drugs, but the major things that are missing is just how we're using them. And I think that's the main thing that would help to answer the question.
Is there any data on rates of overshooting blood pressure control and whether that kind of results in some safety concerns for the two drugs?
Yeah, so most of the retrospective studies do report either rates of hypotension or rebound hypertension. And by and large, rates of hypotension are not significantly different in most of the studies, but that is limited by small sample sizes. And so, I think the biggest retrospective study looked at maybe about 100 to 200 patients. And so it's kind of hard to find those relatively rare events. But in terms of significant hypotension, probably somewhere between 5 and 10% is average across most of these studies. And I think there's at least one study that showed the only patients that actually needed intervention were the ones that were on Nicard, which may be explained by the longer half-life, where if you overshoot, you're going to be dealing with the consequences for a couple of hours. But one interesting thing is there was a paper that was published in Neurocritical Care last year that did show that there was significantly higher rates of rebound hypertension in the clevidipine arm. And I know I'm supposed to be arguing pro clevidipine, but I feel like I'm obligated to point that out.
We appreciate your honesty. That's actually maybe this is a good time to unzip those team jerseys and just sort of take off your clevidipine and nicardipine jerseys and put on your regular pharmacist hats. I wonder, what are your real thoughts now that we've kind of gone over the big concerns and the data, and what, if you were in charge of the use of clevidipine and nicardipine in your hospitals, what would you be recommending? And maybe we'll start with you, Colleen.
Yeah, I think it's a great question. And as I alluded to in the beginning, this is something that we don't have in our shop. So there is a little bit of, I'd like to drive that new fancy car and see how it works and see what everyone else is talking about. But I think that while the data is hard to capture, I think it's hard to go full force for clevidipine while the data is not there for finding that difference. In clinical practice, even the time to get to that goal systolic blood pressure varies in these retrospective studies. Some of them list 30 minutes, 45 minutes for each of these agents. And the one that Andy alluded to, when the nicardipine has to come from the pharmacy, it's an hour and a half. So it's something that I think if I saw in clinical practice a faster time to goal systolic blood pressure, I'd be more willing to shell out the money for the brand new car.
Okay. Andy?
Yeah, honestly, I personally am much the same, where I think that this is a great example of the difference between a population and an individual, where at the population level, we have 6 or 7, they all have their flaws, of course, but, single center, reasonably well done retrospective studies that look at overall in a general stroke population, including ischemic, hemorrhagic, subarachnoid strokes, with varied goals. They're all over the place. By and large, the difference in time to goal attainment, assuming you subtract the time that it might take the pharmacy to compound the nicardipine, they're not really that different. And so I think that probably speaks to the clevidipine just not being used in a way that it could be used, because at least in the 2 prospective studies in this population, so Accelerate, which was in spontaneous ICH, and then the Clash trial, which was a tiny pilot trial in subarachnoid hemorrhage. In those 2 studies, when they did intentionally use clevidipine in the way that it was intended to be used, you did see faster time to goal. And so I think my kind of takeaway between those 2 disparate conclusions is that in your average patient who needs a continuous infusion to get good blood pressure control, nicardipine works just fine. It gets you to your goal in a reasonable amount of time. It's familiar. It's generally pretty reliable. And most people know how to use it and know how to titrate it. Interestingly, at MGH, we don't have the premixes, but we actually stock the vials in our dispensing cabinet, and nurses snap it together with a mini bag plus vial. So we kind of have the best of both worlds, where we have the cost savings of the generic vials, but the ready availability of it being on the unit. And so we are kind of in a luxurious spot where both are equally available. But if you're, say, like this has happened a handful of times, or say somebody is in the emergency department and they get Tenecteplase and they come up to the unit and everything's going great, and then in the hour 2 or hour 3 neuro check there's a dramatic change, and so everybody rushes to the scanner with the patient and they have this big bleed, and it's a true all hands on deck scenario of who's going to get the cryo, who's going to get the TXA, who's going to get the blood pressure meds. In those sorts of scenarios where there's a lot of resource available to kind of have every single piece in place, I do like clevidipine more, because in that scenario, oftentimes I could be the one at the pump, and they may already have, if they're probably recycling blood pressure frequently, or if you're really lucky and they have an A line for whatever reason, you can titrate it rapidly to get control, but only if you kind of have the capability and the time to do that. And so I think my personal practice is that our first line continuous infusion for your average patient, it would be nicardipine, but there are definitely instances where I do believe that clevidipine has an edge, but only if you use it right.
So I'm hearing that clevidipine should come with its own little pharmacist directing all the titration. I love it. I wish that each one of our Clevi bottles came with a PI of a study or a pharmacist to direct rapid titration. Well, I want to really thank both of you for your time and your incredible expertise on this topic. I loved hearing about your sort of real life experience with these medications, but your knowledge of the literature is really impressive. So thank you so much to both of you for your time. And I can't wait to hear this debate in a couple of years, see what's been happening at both your institutions.
Yeah, thank you so much for inviting us on.
Yeah, thanks. This was fun.